Hello, everyone. Thank you for joining us today. My name is Rose Gerber. I'm the Director of Patient Advocacy and Education for the Community Oncology Alliance. As you can see today, it's a very, very special day for us. The entire month is special. It is Cancer Survivors Month, and I'm happy to say that I'm a long-term survivor. And for those of you who can see Shelley on the screen, Shelley Fuld Nasso is the CEO, which is impressive on its own, of one of the most important national cancer organizations, actually known globally for the work they do for cancer patients. They are very, very, you can see it in the name, patient focused. And every year they do a cancer survivorship report, which brings forth such interesting information. I apologize, I've been sick the last couple of days, and Shelley is going to take us through some very important information. If you have any questions for her, please put it in the chat. These 30 minutes fly by. I'm going to your appreciation of many, go put myself on mute so you don't hear my coughing. So Shelley, thank you so much for being here. Oh, and one very important thing, I also want to express my gratitude on behalf of COA to all the amazing cancer patients and survivors and doctors, pharmacists, and nurses, and everybody who joined us on COA's recent Hill Day. So thank you so much. And Shelley, thank you for being with us today. I look forward to learning from you, and so do all the other cancer survivors and caregivers and everybody who's been touched by cancer. Thank you so much. And now I'm going on mute.
Thank you, Rose. I'm so sorry you're not feeling well, and I hope you feel better soon. And I'm really honored that you gave me the chance to come and share about the results of our State of Survivorship Survey. I think for the cancer survivors and caregivers on the call, you'll see that what our survey really, it'll probably resonate with you because we have done this survey for 6 years now, and we ask survivors and caregivers about their experience from diagnosis through treatment, through post-treatment survivorship. And so I'm going to share with you the results of last year's survey. Next slide, please. And these are our sponsors. Next slide. And just I want to mention, actually, what I'm going to do is in the chat, I'm going to put a link to where you can see all of this on our website. I'm going to be sharing a subset of the slides because there's a lot of data there, and I want to make sure that there's time for questions. So please, you can put any questions in the chat, and I will do my best to address them. I also want to say that if you are interested in participating in the 2025 survey, which will be in the field in July, you can go to if you go to that link that there should be a pop-up where you can sign up to hear more from NCCS. And if you do that, you'll get an invitation to participate in the survey. So what we do, and the methodology, and this is consistent with how we've done it over the years, is we have a national sample that we recruit using quotas to make sure that it's representative by age, gender, race, ethnicity, and region. And we use ACS and NCI data to try to make sure it's a representative sample. We also have our NCCS connected. So if you happen to be on our mailing list or follow us on Facebook and you see an invitation to participate in the survey, you would be part of that NCCS connected. The reason we do two different samples is that the people that find us, whether they're actively involved as volunteers or just happen to follow us on Facebook or be on our mailing list, are more engaged in decision making about their care, are less satisfied with their care overall, and we've seen that consistently over the years. And also they skew younger, and so they're not as representative of who has cancer in this country. So having that national sample allows us to make sure we're not just talking to the people that we talk to every day, but maybe the people who don't reach an advocacy group or don't get the support services that they need. So we had 1,600 patients in that national sample. We also oversampled younger patients, and we partnered with Stupid Cancer, an organization that focuses on adolescent and young adult cancer survivors. And we've seen differences. We kind of look at different burdens of cancer based on different demographic groups. And consistently, we see that young adults are harder hit by many of the aspects of cancer. And so we wanted to have, usually we have maybe 100 young adults in the sample, and we wanted to have a larger sample. So we oversampled, and we produced a separate report for stupid cancer that's available on their website that really delves deeper into we have some of the data about younger patients in our survey, but their report actually goes even deeper and kind of compares people ages 18 to 39 compared with people 40 and over and how they responded to the questions to really show how the cancer experience is different for the young adults. And then we had 674 of the NCCS connected. We also included a little over like 550 caregivers this year, and I'll show you some of that data. Next slide. So some of the key, this is just kind of the highlights of the key findings, and then I'm going to go into more detail on some of them. So when it comes to treatment decision making, a majority of cancer patients still rely on their doctor to choose the best treatment for them. And when we say choose, we give them the option to say, you know, that they are somewhat involved. And so a lot of people still want to defer to their doctor. And so there's a lot of focus in the advocacy community about empowering patients to be engaged in their care. And we absolutely should do that. But I think we just have to remember that there are some people who, at the end of the day, they may learn about their cancer, they may be engaged, they may ask really good questions, but they're still going to say, what should I do? And ask their doctor to make that decision for them. So the way I think about it is we want to empower people to be engaged in their care, but we want people to get the best care possible regardless of how engaged or empowered they are. So if somebody is overwhelmed by their diagnosis and does not want to or have the capacity to do all the reading and research that they would need to do to understand the treatment options, they should still get the best care even without having to do that. We do see that younger patients and certain groups are more engaged in decision making. So I think that's going to change over time. I think that part of that, deferring to the doctor is a function of the fact that about half of our sample is people that are 65 and over, because that again is representative of who has cancer in this country. Even though we've seen a lot of reporting and data about more early onset cancer, it's still overall a disease of aging. So even as we have more young people diagnosed, cancer still affects older people the most. And so I think that some of our older, survivors are more willing to defer to their doctor. We also see that the doctor's recommendations are the main driver for clinical trial participation and the main barrier. So we'll get into that a little bit more. As far as care experiences, we ask people about their satisfaction with their care across, like from diagnosis, treatment, post-treatment. We have consistently seen a high level of satisfaction. People are grateful to be alive and they're satisfied with the care that they got. They're grateful to their healthcare team that got them through. We do see differences in those connected patients. Maybe they have higher expectations, so they're a little bit less satisfied. And we do see differences for caregivers who maybe have a little bit different perspective from their loved ones. We also ask in the care experiences about side effects that people deal with and financial impact. So I'll share some more data on that. And then we ask about post-treatment care. So 2/3 of the patients who are within 5 years of finishing treatment say they're receiving post-treatment care. That means that 1/3 of the patients who are within 5 years are not receiving post-treatment care. Now, there are probably some cancers where maybe they don't need to if it was truly, maybe a surgery only, but the majority of people need some follow-up care. So I think that's a little bit concerning to us to see that some people are not. We also ask about who provides that post-treatment care, and we'll talk about that when we get to those slides, because that's really interesting data. So that's just kind of an overview, and now we'll go into some more of the details. Next slide. So treatment decision-making, next slide, please. Okay, so this slide is some questions about the patient and caregiver mindset. And so the different, we kind of broke it out by the national sample for the patients, the national sample for the caregivers, the NCCS connected patients, and then younger patients, so that we can highlight some differences. We see, for example, caregivers are, sorry, I forgot to mention, anything that's in blue is statistically significantly higher and red is statistically significantly lower. So caregivers are more focused on maintaining quality of life than patients. And then the NCCS connected patients are less likely to focus on the quality of life. So I think that goes to people, if people are thinking about getting rid of the cancer no matter what, versus maintaining quality of life while going through treatment. One thing that was new, sorry, also, when we talk about wanting to find out all I can about my cancer, nationally, 60% of patients said that. Caregivers more likely. So they're the ones who, if the patient is feeling overwhelmed and not having the capacity to do that research to understand their treatment options, their caregivers are the ones doing that in some of those instances. But then also you can see the connected patients and the younger patients are more likely than the average to want to do all the research that they can. We asked a new question this year. I have to advocate for myself in order to get the best treatment and care. A little over a third of all of patients said that, but the NCCS connected and younger patients, more than half, said they have to advocate to get the best treatment. And then also you can see in the box on the left that the Black respondents, Hispanic respondents, people living in urban areas, people with lower incomes, and women were also more likely to say they had to advocate in order to get the best care. We also ask about ignoring symptoms before getting a cancer diagnosis or not wanting to think or read about cancer. It's fairly low, 10%, but you can see of the not wanting to think about it, it's higher among younger adults because it's so overwhelming as to have a cancer diagnosis at that stage in their lives. Next slide. So this was the question about treatment decision making and the doctor knows best mentality. So this is a question we've asked every year in our surveys. So this is the last 5 years of data on that. And in 2020, it was almost 3-to-1 relying on the doctor to choose, not just recommend, but choose the best course of action versus being very involved in researching or somewhere in the middle. And then we saw a big drop in the relying on the doctor knows best mentality in 2021, which we attribute to the pandemic. And then it's been creeping up every year. So we're back to more than half saying that they rely on the doctor to decide on the best treatment course. But then if you see the connected patients, it's only 30% who say they rely on the doctor to make the decision. And they're more likely to say that they are very involved or somewhat in the middle. Next slide. So importantly, we broke out that question about decision making to different demographic areas. And so, as I mentioned, we see that more in older adults. So we did ask about their source of insurance. So you can see that among Medicare Advantage, people with Medicare and Medicare Advantage, they were more likely to say they rely on their doctor. The younger patients and Black and Hispanic patients are less likely to rely on their doctor and more likely to say that they're very involved in research and deciding on the best treatment options. So the seniors also, 58% of the seniors said that they're deferring to the doctor, whereas the young adults, only 30%. Next slide. So a new question that we asked this year was, did you seek a second opinion at any stage of the experience? Only 29% overall said that they did. And that was higher among the NCCS connected. And then the groups listed their younger patients, Hispanic, LGBTQ, stage 4, et cetera. So we asked if the answer was no, why did you not seek a second opinion? And the overwhelming reason is trusting the doctor or healthcare provider. And that is not surprising given what we saw about treatment decision making. And by far, well behind that did not want to wait to start treatment. So that is a factor, but the trust in the healthcare team is the biggest factor. We thought 29% overall was fairly low, but it's not clear what the number should be. But in talking to some experts and oncologists and some of our board members, we think it should be higher. So one of the things that we're doing later this year is we're going to do an educational campaign about the importance of second opinions and why you should do it. How do you go about doing it? You're not insulting your doctor if you ask for a second opinion. You can ask for a second opinion and to confirm what you heard from the first doctor, and then you stay with that doctor. So it doesn't necessarily mean that you're changing your doctor or healthcare team. So I think that was a really interesting finding last year, and it's helped us with thinking through some of our educational efforts.
I'll try to get this comment out. Also, the doctors don't mind. Their doctors
Yeah.
are not insulted. I see that the
Right.
doctors do not mind. A lot of patients think the doctor will mind, and the doctors do not mind at all. They encourage it.
Most of them do, and if they don't, then maybe that's a sign, but I think that's right,
Red
that
flag.
the vast majority of them do not mind. They understand you have to be comfortable with your treatment, and if that means getting a second opinion to feel like you've thought about all of your options, then that's something you should do.
Thank you, Becca.
Next slide. So we also ask about clinical trial participation, and it's been pretty consistent over the years. 9 to 10% said they participated. And we also usually, we ask the question of were you offered a clinical trial, and we don't see the rates being much higher. So this year, one thing new is if you did choose to participate, we asked why, and the number one reason was the doctor's recommendation, also wanting to contribute to science, and that one was higher among the NCCS connected. Also in the bottom left, you can see the groups that had a higher rate of saying that they did participate in a clinical trial: younger patients, Hispanic patients, people who also receive palliative care or immunotherapy, etc. Next slide. So we asked if you did not participate in a clinical trial, why? And the number one reason by far was they were not asked to participate. There's also, eligibility, concern about side effects. I think to me, the importance of this is there's so much, in the advocacy community know that diversity in clinical trials is important. We want to make sure that the people who are in the clinical trials will represent who will be taking the medicine if it's approved. But it's I think a lot of the focus is on breaking down barriers for people and educating patients about clinical trials, but they're not going there's some patients who will ask about clinical trials, but if we rely on the patient to bring it up, we're not going to make headway in diversifying clinical trials. They really need to be asked. Now, when you see that younger patients, it says 51% said that the reason they didn't participate was that they were not asked. That means they were more likely to be asked, which makes sense. We know that sometimes older patients are not included in trials for various reasons, including their health status. But so the younger patients were more likely to be asked. And so if they didn't participate, they had other reasons like concern about side effects, concern about the type of treatment they would receive, concerned about cost. Similarly, the Hispanic patients and Black patients Hispanic actually was statistically significantly different, that they were more likely to be asked and didn't participate for other reasons. Next slide. Cancer care experiences. Next slide. So we ask about satisfaction with care, and this is consistent with what we see every year, that in the vast majority of patients are very satisfied. However, if you look down at the bottom, the younger patients are much less satisfied with their care. 20 points lower, 20 or more points lower across most of the domains. We also ask only of patients with a stage 4 diagnosis if they were satisfied with end-of-life planning and care. And that is a much lower and more saying that they're unsure or it's not applicable. So it's most likely people, it's probably some who maybe should be having some conversations about end-of-life planning, but also people who are doing really well on their, with stage 4 cancer, and it's not something that is in the cards right now to have those conversations. Next slide. So then we add on the caregiver satisfaction, and the caregivers across the board are, 20 points lower across most of these domains. And I kind of think of this as the truth tellers, right? The patients are happy to be alive, grateful to their care team. The caregivers saw the challenges that their loved one faced and are maybe less satisfied. They're grateful that their loved one is alive, but they kind of saw those gaps in care or challenges they faced in receiving care. We did see, though, that with end-of-life planning, because some of our caregivers cared for someone who had passed away recently, so they had a higher satisfaction with that end-of-life planning. Next slide.
Thanks.
Yes, go ahead, Rose.
Shelley, I just want to draw your attention to some Q&A for you.
Oh, okay, great, thanks.
Oh,
Um,
it's regarding, I'm sorry, let me see if you can see that. Do you feel it would be beneficial to survey docs, healthcare providers about how often they speak to their patients about clinical trials? It may help build an HCP education program around this, and then I'll let you answer, and then I can add a comment from the community oncology standpoint.
yes, I do think it would be. I also think it's partially about talking to their patients about trials, but I think partially it's about reducing the structural barriers to
Yeah.
participation.
And I can speak to that from the perspective of a cancer patient who was on one of the groundbreaking trials. Anyone who knows me in the advocacy space, I was on the Herceptin clinical trial, and I was asked by my oncologist. I did not ask to be on a trial, so that proves the point. I can't speak for every community oncology practice in the United States, but many of our community oncology practices are structured to immediately ask the patient if they would like to be on a trial, again, assuming, they've already looked at their profile. But again, I can't speak for every practice out there, but there is a staggering amount of clinical trial information currently being offered. But yet, Shelley and I both know the number of trial participation is still staggeringly low, has not really moved since I was on a trial over 20 years ago. Thank you for your questions, and you can continue putting them in the chat.
Thanks, Tricia. Okay, so we asked about side effects experienced, and one thing that we added this year was fear of recurrence. We did not have that listed, and it came up at the number 2 most frequently reported. We revised the wording of pain. We had previously called it muscle and joint pain, and when we just changed it to pain, it went up because it was a more expansive definition of pain. But you can see almost all of them, with the exception of sexual concerns, were more likely to be reported by women than by men. And then young adults had higher rates of many of these than the overall sample. We also asked which side effects impacted you the most, the top 3. And the ones that were most likely to be reported as the most impact were fatigue, fear of recurrence, and depression, anxiety, and mental health. So we usually see that the things that we know how to treat, like with medication or with therapies, it's like nausea and vomiting, we people see as they're less impacted because they have support for it, and they feel like previous years we've asked the question of how helpful was the healthcare team in addressing the symptoms, and consistently we see that like the things like that are the biggest impact to patients because they're not getting that help are the fatigue, fear of recurrence, depression, uncertainty, things like that. Next slide. Financial impacts. So overall, 44% had at least one of these financial impacts. But again, that 44% is really colored by the fact that half the respondents are Medicare beneficiaries, and they have better insurance because they have Medicare or Medicare Advantage. So you can see the difference over on the right-hand side. The people who had Medicare, only 36% had one of these financial impacts. People with non-Medicare based insurance had 46% had at least one of these. All the blue is statistically significantly higher. So you can see that the young adults, 90% had one of them. African Americans, 55%, Hispanic, 68%. etc. So these are just kind of the top financial impacts, but most people had at least one. A couple of new ones that we added were the patient had difficulty affording prescription drugs or trouble getting insurance to cover screenings, stopped, took less in, or switch meds because of cost. Those were new that we added this year. Next slide. So we asked about employment during treatment. So we asked if you were employed during treatment, what best describes you. You had to keep working, you wanted to keep working, or somewhere in the middle. For patients, they were more likely to say they wanted to keep working because they wanted that sense of normalcy. Caregivers more likely felt like they had to, they didn't have a choice, but they would have rather not been working so that they could have more time to care for their loved one. Next slide. So we asked about effect on productivity, and about 30% of patients said no effect on productivity, up to 15% that said it completely prevented them from working. But we can see that the younger patients were more likely to say they had their cancer treatment had a large effect on their productivity while working, and much less likely to say it had no effect. Next slide. And then these were some of the impacts: missed work, lost salary or wages, et cetera. But I think what's really important here is the missed work. So we asked, how many hours per week did you miss in a typical week as a result of cancer treatment? So for patients, 21 hours; for caregivers, 15. I mean, that's essentially half time. So it just, highlights what a burden it is. Like if you're trying to continue working through a cancer diagnosis, it's really challenging. And I think this year we may ask some additional questions about what supports from your employer would be helpful in letting you continue to work during a cancer treatment.
Shelley, I'm going to attempt one more question. Can you go back one slide? Was it the younger people had a more difficult time during treatment than the older people? Did I get
Yeah, to continue working.
that?
Yeah. They had a bigger effect on their productivity.
Is that a surprise finding or no? Does that seem more surprising? Or is it,
Um, I don't know. That's a good question.
it's kind of interesting to me.
It is interesting. I mean, I'm not completely surprised by it, but I think
Is it an emotion? It's almost an emotional impact. I don't know. It seems kind of
it could be
interesting.
that, and it also could be if younger people have
Less resources, maybe.
less resources, jobs that aren't as accommodating,
Maybe that's
that
probably
maybe don't have
insurance or
flexibility
right.
and ability to work remotely or things like that.
Thank you.
And I just realized it's almost 12:30, so I want to get to the post-treatment, so you can go ahead. Oh, these were just some of the impacts on caregivers. Their biggest challenges for the people with a loved one with stage 4 cancer who had passed the end of life was the most burdensome, but then having the emotional support that you need, being there for friends and family, having the energy to make it through the day, etc. Next slide. One more. So I mentioned this in the overview that 2/3 say they're in the care of people 5 years or less, that they're under the care of a healthcare provider for post-treatment care. And then that means a third, that means a third or not. Also, of people over 5 years, only about a third say that they're receiving care for post-treatment. So if they're not receiving post-treatment care, we asked why, and the biggest reason was their doctor said there's no need for post-treatment care at this time or anymore. Which is not really our experience, so that's a little bit concerning because we know that patients have concerns and needs that they want to get addressed in post-treatment. Next slide. We also asked, who is the primary healthcare provider managing your post-treatment care? And interestingly, we've asked this question over the last 3 years, and we've seen a steep decline in people saying that their primary care provider is the person managing their post-treatment care, and an increase in people saying their oncologist is. And there's a lot of talk about moving more of post-treatment care to primary care because oncologists are busy, have that are focused on people who are in treatment, don't necessarily have the capacity, but yet we see patients less likely to rely on their oncologist. Although we do see for folks who are 5 years or more out, it's more evenly divided, whereas people who are, less than 5 years are much less likely to see their primary care provider. Next slide. And I believe this is the last one, willingness to see a primary care provider for post-treatment care. About a little over a third said yes, and less so for NCCS connected patients, because I think they're more aware of post-treatment survivorship needs and the idea that they need someone who really understands the treatment that they receive to be able to help monitor long-term effects. So I am sorry if I went too long, but if there's time for any more questions, I'm happy to take them, but you can also find out more on our website. And again, if you sign up, you will get well, first of all, on your website, you can download this deck and you can see the things that we're not going through because we don't have time. But also, if you sign up, you'll get a link to participate in the survey next month when it comes out.
This is wonderful, and you only went over by 1 minute, which was absolutely worth it for Survivorship Month. Thank you for all the great information. Thank you to all our participants. And this again will be on COA's YouTube page, Facebook, everywhere else. Thank you so much, Shelley. And again,
Thank
thank
you.
for all the survivors that you're helping today and every day. And we have one last slide. We will see you all, let's see the date, on July 9th. Enjoy the rest of your day. Thank you so much, Shelley.
Thank you.
Thank you,
Hope you
everyone.
feel better.
Thank you so much. Bye-bye.